Guillain-Barré syndrome. This is not a primary problem. This is a complication resulting from usually a viral problem and also a certain bacterial infection. So what is it? It's an acute idiopathic. When we say idiopathic, what does that word mean? We don't know. Okay, so from the word idio, okay, like idiot, okay, no, we don't know. It's polyneuritis. It's considered an autoimmune problem. So what happens here? The patient's own body, own immune system will attack the myelin sheath of the nerves, resulting in the symptoms. So there is acute, rapid, segmental. That means it's not going to affect the entire length of the nerve. So it will be segments of demyelination. What's the purpose of the myelin again? This covering of the nerves. What's the purpose of that tissue? So actually, it's to facilitate the transmission, right, of the impulses from one nerve to another. So these are the manifestations. It will affect some cranial nerves. The patient will have ascending weakness with dyskinesia. Dyskinesia is involuntary um, uh, inability to do voluntary movements, so therefore involuntary. Hyporeflexia, meaning low reflexes, and paresthesias. You know what paresthesias are, right? Okay. As I said, the most common cause, meaning most cases, involve or show that the patient had a recent viral infection. Could be the flu, could be COVID. It could even be a flu vaccine, right? Some people never had the flu, but they remember having the flu vaccine recently. So that's most of the cases. 60 to 70% of those cases involve some recent viral infection. And like I said, including the flu vaccination. Some cases, the remaining 40%, they develop the Guillain-Barré after having a Campylobacter jejuni bacterial infection. So what are the causes again? So is this a primary condition or occurring on its own? No, it's an autoimmune disorder arising after a viral infection, including flu vaccination and Campylobacter bacterial infection. Other smaller cases are from Epstein-Barr, Mycoplasma, or the flu, like I said, or even the Zika virus. The most common type is, of course, the the ascending type. So Guillain-Barré syndrome, the patient will have these manifestations acutely. They were fine yesterday, they woke up with these symptoms. So most patients report that they just got up one morning, and then when they stood up, they fell because their legs could not bear their weight. Okay, they report now the paresthesia, the dyskinesia, and the weakness or eventually paralysis of the legs. So the symptoms will progress, get worse over the next few days. And the important here is for us to be able to either shorten the period, and because it's self-limiting, and shorten the period and then facilitate recovery, is the patient must seek intervention within 2 weeks from the onset of symptoms. Now that can be difficult for some patients. Say you don't have any insurance, right? So are you encouraged to seek help? Okay, so some patients are in a tough spot, right? Some patients may have insurance, but then they realize the insurance doesn't have good coverage and they end up with a lot of copay, right? So that can also be another, let's call those people underinsured, okay? So that can be a discouraging factor for them to seek help, and then the patient will have a pretty poor prognosis. Look at the incidence. 1 to 2 cases per 100,000 people. It's quite rare, but it could be that 1 to 2 cases. The problem here, the cause of death really is the complications that result from the paralysis, because the patient will have ascending paralysis, meaning first it'll be their legs, their feet, and then their legs, and then the thighs, and then eventually it will affect the diaphragm. So can these patients breathe? No. So they'll end up on a ventilator, and complications result from immobility. So they could die from a blood clot, from a DVT or a PE, or even a stroke. All right. So you don't die from Guillain-Barré. You die from the complications that this thing causes, because you could be intubated. Again, if you seek help too late, there are 2 successful treatments that will facilitate the shortening the period and then preventing the eventual need to be intubated. But again, they're only effective up to 2 weeks from the onset of symptoms.
So you intubated the patient before the patient get intubated before getting.
What do you think? Yeah. Yeah. All right. So that's the whole description. If you like the book's description better, have at it. Okay, that's the best way I could describe the pathophysiology. Manifestations again was mentioned under pathophysiology earlier. So it's ascending. The pattern is always bilateral. Okay, both feet, both legs, both thighs, and then eventually up. It will affect all muscles, including the diaphragm. GBS progresses to peak severity 2 weeks and no longer than 4 weeks. Again, the longer this patient go without treatment, then the patient will have they'll have polyneuropathy, which means they could have this for a long time, possibly for life. They may not recover fully. I mean, like I said, this is self-limiting, but then it will leave you disabled, okay, unless you get treatment early. Let's go to the testing, of course, there's no specific test that says, oh, this is Guillain-Barré syndrome. There's nothing like that. There's no blood test. There's no MRI or CAT scan, but they will perform all of these tests. They'll do blood tests. They'll do an EMG. They'll do CSF analysis. They'll do a lumbar tap. They'll do MRIs, CAT scans. But these tests are only to show if it's not other causes. Does that make sense? Meaning we're trying to rule out other causes. That's really the point of all the testing. We're not trying to prove Guillain-Barré based on the testing. Does that make sense? Because there is none. So we just look at the patient's clinical picture and then rule out other causes. Is this a spinal stenosis problem? Is this a meningitis problem? Okay, so that's why they do all those testing. Once they rule out other causes, then they arrive. Okay, our suspicions are confirmed. You have Guillain-Barré syndrome. Okay, because we did MRIs, doesn't show this and this. Make sense? All right. So let's go to the 2 treatments. There are 2 choices here. The patient will either receive plasma exchange. Remember plasmapheresis? We talked about this last semester during your presentations. Okay, plasmapheresis. Plasma exchange, it's like a dialysis. The only difference is, instead of removing waste products, what are we removing? Plasma. And we're giving you somebody else's plasma. Okay, so that's what therapeutic plasma exchange is. Disregard and here, because I think the statement just says therapeutic plasma exchange and IVIG are used, but one patient won't get both. It's a waste. It's either one or the other. All right. So it's either you get plasma exchange or you get IVIG. The decision to pick which one is cost one. Let's start with IVIG. This thing costs about, last time I checked, was $1,500 per gram. The dosing is based on weight. So the bigger your weight, the higher your dose, the higher the cost. So one infusion could cost upwards of 20 grand, depending again on your weight. And it's not one dose. It'll be a few doses a week, and it'll be a few weeks. All right, so this can rack up easily to $500,000. All right, if you choose this option. The other option is plasma exchange, which will be a few times a week, okay, just like dialysis. So which one's cheaper between the two? The plasma exchange. The plasma exchange is definitely cheaper. As far as,
Question, will insurance cover that, the one with thalassemia?
of course, they cover, but how much? I don't know. Ask your insurance. Okay. Because since they gutted Obamacare, there's now a cap on your lifetime benefits. Unlike with Obamacare, there was no cap. Meaning that's why insurance companies didn't like it, because there was no limit to, in your lifetime, how much the insurance will spend. Now there's a cap. So yeah, you could be on the hook for the rest once you reach your cap. So plasma exchange, you still remember complications? There's, I think, a chart. Let's see. Obviously, it's not on this page. It may be under myasthenia gravis. Let's see. Yeah, right here. So plasmapheresis is in the previous page under under myasthenia gravis. We did myasthenia gravis last semester. Okay. So just review it here.
The page not showing it.
Because of this, but you can figure it out. So when is the treatment period again for this to be successful? Within 2 weeks from the onset of symptoms. The sooner, the better. If it's beyond 2 weeks, the doctors typically would not recommend treatment anymore. It's too late. It's not going to do any good. Okay, they won't even recommend plasma exchange or IVIG. We're just wasting our money, because statistics show, from history, they don't work anymore if it's beyond 2 weeks. So time is really important here. Let's review a few problems with plasma exchange. So you're removing someone's plasma and giving them someone else, but during the exchange, what could happen? What's in plasma? Protein, clotting factors, and antibodies, right? It's mostly water. So as water, antibodies, clotting factors, and protein. So what could go wrong if you're removing them? What happens to blood pressure? Drops. What happens to bleeding? Increases bleeding. What happens to your immunity? Okay, could leave you at risk for infections. And what happens to your fluid balance since it has protein? Could you have edema and stuff? Yes. Okay. We'll discuss mechanical ventilation later under airway management. But these people eventually may need, especially if they don't receive the plasma exchange or IVIG, they'll end up on a ventilator. For IVIG, complications really is on the wallet. I mean, your wallet will get skinny. No, for real. Complications from IVIG would be some uh, allergic reaction, maybe to the contents of the solution. That's about it. Allergic, or it could be anaphylaxis also, but that's extremely rare. That's about it. The IVIG, your wallet will feel it, and some allergic reaction during the infusion. Any questions on Guillain-Barré? So the rest here for nursing, again, respiratory support, especially if the patient's symptoms now reaches the diaphragm. You have to know when. One last thing, because this is a breathing muscle problem, it's a diaphragm muscle. Is the lung really affected here? No. So what will be the basis for your assessment of the respiratory function? Is it the oxygen saturation or the vital capacity? The vital capacity. There's no gas exchange problem here. The lungs are totally fine. The problem is with the breathing muscle. The diaphragm is paralyzed. So that's your evaluation assessment. Assessment evaluation. It's really the patient's vital capacity, not the oxygen saturation. Are we clear? If we come to this, the patient will have bulbar weakness. What do we mean by bulbar? Okay, so the bulbar muscles are those involved in chewing, speaking, and swallowing. So all those muscles there are called collectively the bulbar muscles. So what will happen if it affects now, it reaches the head and the patient still swallow. So how do they eat? Feeding tubes. So they won't be able to clear secretion, so they need to be suctioned. And prevention, again, these patients are paralyzed, can't move, so DVT and PE precautions. Do range of motion exercises, do the sequential compression or give them heparin. And pressure ulcers also, prevention. Communication, this will also be affected by the bulbar muscle. So use a Ouija board for them to communicate. All right. Any questions?